Hello, my name is Renee Quarterman. I'm a breast surgeon at Delaware Breast Care, and I'm happy to present breast cancer de-escalation of axillary surgery. Regarding disclosures, I am a women's health advisor with Natera. The objectives of my presentation are to point out basic axillary anatomy, demonstrate the evolution and roles of axillary surgery in breast cancer care, explain current standards of care for axillary surgery, and to briefly explain some information around lymphedema. This is a simplified picture of basic breast anatomy. You have the lobes and the ducts, the functional elements of the breast, surrounded by stroma and fat, the supportive elements of the breast. The lymphatic drainage is predominantly into the axillary nodes. Looking more closely in the axilla, the nodes lie predominantly below the axillary vein between the latissimus dorsi and serratus anterior muscles. There are 3 levels of lymph nodes. Level 1 is lateral to the pectoralis minor muscle. Level 2 is posterior to the pectoralis minor muscle, and level 3 is medial to that muscle. Contemporarily, when we discuss node dissection, we're referring to all of level 1 and some of level 2. So let's get into some history to better understand where we are now. The National Surgical Adjuvant Breast and Bowel Project, or NSABP, Study 04, examined surgery for breast cancer. Preliminary results were published in 1977, and 10-year follow-up data was published in 1985. The goal was to determine if one could do less surgery for breast cancer with equivalent success. Long story short, the answer was yes, and this is why a radical mastectomy for breast cancer is no longer the standard of care. But what I want to bring to your attention is the group on the left-hand side of this plot, those with clinically negative axillary nodes. That means no palpable lymphadenopathy. They were randomized to radical mastectomy, meaning removing the gland, the pectoralis major and minor muscles, and axillary lymph node levels 1 through 3. Total mastectomy with radiation, leaving the axillary lymph nodes alone, or total mastectomy alone, no axillary node surgery. The patients in these 2 groups were treated with axillary lymph node dissection if they developed nodal disease down the line. All groups had equivalent disease-free and overall survival. Again, focusing on these ladies on the left with clinically negative axillary lymph nodes, while local regional recurrence was lowest with total mastectomy and radiation therapy, leaving the axillary lymph nodes in place and only removing them if they developed disease did not affect overall survival. Do you need to remove axillary nodes that are normal in appearance? This study strongly suggested that the answer was no. These research participants were followed along, and updated findings were published in 2002. And as you can see by these graphs, the disease-free and recurrence-free survival rates were persistently equivalent, looking just at the node negative curves for our purposes, at 25 years of follow-up. In the node negative group of the recurrences, over 75% were either distant or in the contralateral breast, not in the ipsilateral axillary nodes. This slide shows the equivalent distant disease-free survival and overall survival within the node negative and node positive groups. This article was included in a review in 2013, and the authors noted that in the node negative group in that B04 trial, 40% of the patients with radical mastectomy had positive lymph nodes on surgical pathology. Now, since these groups were randomized, one would expect that 40% of the patients that didn't have axillary surgery would also have had positive lymph nodes. 19% of the patients in that group developed positive lymph nodes and had axillary lymph node dissection later, but they remained in the follow-up cohort. They did not affect their survival outcomes. This suggests that routine axillary lymph node dissection for patients with a clinically node-negative axilla is unnecessary, and omission of this procedure until there is clinically evident disease in the axilla will not have a significant impact on overall survival. Now, mind you, this was in patients who had mastectomies, because at the time of this trial, lumpectomies were not being done. And as lumpectomies were being evaluated and later shown that lumpectomy and radiation would have equivalent disease-free and overall survival compared to total mastectomy, full axillary lymph node dissection was being done virtually for all breast cancer patients being operated on. And why was that? The benefits are deemed to be: one, staging. You get a full picture of the cancer, and that can provide prognostic information and make some therapy recommendations. Axillary node dissection can guide adjuvant therapy recommendations. It can provide regional control. And the rate of nodal disease was traditionally 20 to 35%. So you might be gaining some benefit by removing these lymph nodes. The risks of axillary lymph node dissection are significant. They include lymphedema, shoulder dysfunction, pain, and paresthesias. So a full axillary lymph node dissection, levels 1 and 2, was standardly being done in breast cancer surgery regardless of clinical node status. But then the concept of the sentinel lymph node was discovered. Node evaluation for melanoma revealed that lymphatic drainage of target areas could be tracked to a specific nodal basin, and the first nodes to receive drainage in that basin could be tested for disease. If those nodes were negative, it was oncologically safe to expect that the rest of the lymph nodes were negative and could be left behind. This would thus reduce surgical morbidity. And in 1994, this article by Giuliano and colleagues demonstrated the ability to identify lymphatic drainage from the breast to the axillary nodes and to localize the sentinel lymph nodes. The nodes were successfully identified in over 65% of the cases, and they accurately predicted axillary nodal status in over 95% of patients. This study proved that accurate identification of the sentinel lymph node was possible in breast cancer. This led to the NSABP B32 trial, which compared survival and regional disease control rates between sentinel lymph node resection and full axillary lymph node dissection. As you see here, women were randomized to sentinel lymph node dissection followed by axillary node dissection, or sentinel node resection alone. In the sentinel lymph node section alone group, those with positive nodes proceeded to a full axillary lymph node dissection. Comparing both groups, local control, disease-free, and overall survival were equivalent. Here's the study setup again, showing group 1, sentinel lymph node resection and axillary lymph node dissection, and group 2, sentinel lymph node resection, then full axillary lymph node dissection only if the sentinel lymph nodes were positive. Overall and disease-free survival were equivalent between both groups. So this study changed the paradigm in breast surgery. Rather than axillary lymph node dissection for all patients, the sentinel lymph node dissection became the standard of care in clinically node-negative disease. Now, it's usually done this way. A radioactive substance, a technetium sulfur colloid, as well as a blue dye, isosulfan or methylene blue, are injected into the dermal tissues or the subdermal tissues in the breast, usually in the subareolar position, but sometimes or additionally around the tumor. The substances travel through the dermal lymphatics into the primary drainage basin, which is usually the axilla. And the sentinel lymph nodes will be blue and radioactive. Those are removed, and that is the sentinel lymph node biopsy procedure. This allows many patients to have less axillary surgery because a majority of patients with clinically node negative disease also have pathologically negative nodes. Patients can be spared significant risks of lymphedema, neuropathy, and shoulder pain. But the next question was, are there cases where patients with positive sentinel lymph nodes can be spared axillary lymph node dissection? Remember, sentinel lymph node resection is done in clinically node negative disease. Remember also in B04 that 40% of patients who were clinically node negative but had, presumably because of randomization, positive nodes did not have axillary lymph node dissection, and their survival was not impacted. Are there modern day situations where leaving clinically node negatives alone, even with positive sentinel lymph nodes, is safe? This was answered in the American College of Surgeons Oncology Group Z0011 trial, published in 2017. The investigators noted that with the introduction of sentinel lymph node resection, the use of full axillary lymph node dissection declined from 94% in 1998 to 36% in 2004. While axillary lymph node dissection is very effective in maintaining local control, it does have its risks, as I've said a few times now. Its necessity has come into question with increased knowledge of tumor biology and the advent of systemic therapies. So the investigators asked, is 10-year overall survival of patients with sentinel lymph node metastasis treated with breast-conserving therapy and sentinel lymph node dissection alone non-inferior to women who were treated with axillary lymph node dissection? Women who had T1 or T2, that's up to 5 centimeter tumors, and no palpable lymphadenopathy were included in the trial. They all had lumpectomies and sentinel lymph node resection. Those with 1 to 2 positive sentinel lymph nodes were then randomized to full axillary lymph node dissection or not. All patients proceeded to subsequent disease-specific care, including whole breast radiation. At 6.3 years of follow-up, there were no differences in disease-free and overall survival. And 10-year follow-up showed that indeed, overall survival and disease-free survival were equivalent. Omitting full axillary lymph node dissection in these cases was non-inferior. The bottom plot shows that while hormone receptor negative patients had reduced survival compared to hormone receptor positive patients, omitting axillary lymph node dissection when 1 to 2 sentinel lymph nodes were positive did not impact survival. This study did not support the routine use of axillary lymph node dissection in patients with tumors 5 centimeters or less in size with clinically node negative disease and 1 to 2 positive sentinel lymph nodes. And this is the new standard. For patients planned for breast conserving therapy, when tumors are T1 or T2 and there is no clinically palpable lymphadenopathy, we routinely proceed to sentinel lymph node dissection. And if 1 or 2 nodes are positive, no further axillary surgery is done. Now, intraoperatively, if the surgeon feels or sees suspicious nodes, whether or not they are sentinel lymph nodes, they're excised and they're counted. And if more than 2 nodes in general are removed, we usually ask for intraoperative pathology evaluation. And this is done because if we know during the operation that more than 2 nodes are positive, we can spare the patient a return to the operating room and do her axillary lymph node dissection right then and there. Now, are there some cases of T1 or T2 clinically node negative breast cancer where one can simply omit sentinel lymph node resection altogether? Well, the answer is yes. The Society of Surgical Oncology has a Choosing Wisely campaign that makes cancer treatment recommendations based on literature review of risks and benefits. It's currently recommended that women aged 70 or older with early stage hormone receptor positive HER2 negative breast cancer not be routinely considered for sentinel lymph node resection. Data shows that omission of sentinel lymph node dissection in this group does not impact local regional recurrence or survival. Now, this is probably because of the success of endocrine therapy, which these patients would presumably take, but each patient should be considered individually. If they can't take endocrine therapy, or if the node status would actually impact adjuvant therapy recommendations, then sentinel lymph node dissection should be pursued. Could axillary radiation actually replace axillary lymph node dissection? The Amoros trial looked at this. They looked at patients with breast tumors under 3 centimeters in size in cases where sentinel lymph nodes were positive. Patients were randomized to axillary lymph node dissection or axillary radiation. And they found that after 10 years of follow-up, that axillary recurrence rates were not significantly different between the groups. And this was presented in 2018 at the San Antonio Breast Cancer Symposium. Disease-free and overall survival were equivalent. So this trial would support axillary radiation when sentinel lymph nodes were positive, but Z11 came out a year earlier saying that no further axillary treatment was necessary in these cases. So the idea of radiating the axilla has not been pursued in patients like this. So we know that sentinel lymph node resection is successful and effective therapy in the setting where surgery is the first step. But what about when surgery is the second step after neoadjuvant chemotherapy? If those patients are ready for surgery and they're clinically node negative, is sentinel lymph node resection feasible and safe? The B27 trial looked at this. So 428 patients had a sentinel lymph node biopsy followed by axillary lymph node dissection. And the sentinel lymph node identification rate was just under 85%. It was highest when both blue dye and radioactive tracer were used. The false negative rate was 10.7%. So it was surmised that sentinel lymph node biopsy is applicable following neoadjuvant chemotherapy. And this is routinely pursued now as a surgical goal when it's time for surgery if there are no clinically suspicious axillary nodes. So what about patients who are clinically node positive prior to neoadjuvant chemotherapy? In these cases, an axillary lymph node has been proven positive by biopsy. And if the nodes look unremarkable after neoadjuvant chemotherapy, can the patient still have a sentinel lymph node resection? The ACOSOG Z1071 trial attempted to answer this question. This was published in 2013. The investigators started with an awareness that prior experiences documented high false negative rates in sentinel lymph nodes following neoadjuvant chemotherapy when nodes were positive prior to starting treatment. So the first challenge was to determine the accuracy of identifying the sentinel lymph node. 756 women were enrolled, and 649 had a conversion to clinically node negative disease following neoadjuvant chemotherapy. The study concluded that the false negative rate for these women was too high to support sentinel lymph node dissection following neoadjuvant chemotherapy in women with node positive disease that appeared to resolve with chemotherapy. The false negative rate was 12.6%. They noted that since the false negative rate for sentinel lymph nodes in cases where nodes were clinically negative up front was 10%, the rate in these cases in this study should not be any higher than 10%. So the next step was to find strategies to reduce that false negative rate. And this was done in follow-up of the same cohort of patients. So within that 1071 trial, subsets of patients were evaluated. These were patients who had axillary ultrasound following neoadjuvant chemotherapy, patients where dual tracers were used to identify sentinel lymph nodes, where at least 2 sentinel lymph nodes were removed, and in patients whose biopsy lymph nodes were marked and removed at the time of sentinel lymph node biopsy. And it was found that the false negative rate of the sentinel lymph nodes was below 10% in those cases. So if the patients proceeded to clinically node negative disease after neoadjuvant chemotherapy, they had a normal axillary ultrasound, dual tracers were used to identify the sentinel lymph nodes, at least 2 or ideally 3 sentinel lymph nodes were identified, and if the biopsy lymph node was removed at the time of surgery, the false negative rate was low enough that it would be safe to do sentinel lymph node resection in those patients. So now sentinel lymph node biopsy has become standard of care for clinically node negative disease when surgery is the first step in treatment and when following neoadjuvant chemotherapy, even when patients initially had node positive disease. This de-escalation of axillary surgery has reduced complications such as lymphedema and neuropathy that impair quality of life, while maintaining disease-free and overall survival rates. So what's next? Perhaps in some patients omitting axillary surgery altogether. This is a trial out of Germany, and initial results were presented at the most recent San Antonio Breast Cancer Symposium. This is called the Encima trial. Over 5,000 women with early stage breast cancer were treated with breast conserving therapy, lumpectomy, and whole breast radiation. They were randomized to sentinel lymph node biopsy or no axillary surgery. Now, long-term, the group will be reporting on outcomes of randomizing women with 1 to 3 positive nodes to full axillary lymph node dissection or nothing. But this data looked at patient quality of life with sentinel lymph node biopsy versus no axillary surgery. And what's remarkable to me is the significant number of reports of arm and hand problems with sentinel lymph node dissection alone, this surgery that we actually consider fairly minimal. I mentioned that the study will also look at women with 1 to 3 positive lymph nodes, randomizing them to sentinel lymph node biopsy alone or completion axillary lymph node dissection. Not surprisingly, those with less surgery report fewer complications. It'll be interesting to learn if it's oncologically safe to do even less axillary surgery, omitting axillary lymph node dissection when up to 3 lymph nodes are positive. This study is already demonstrating that there's a negative impact of sentinel lymph node biopsy, and it can significantly impair comfort and mobility. And if we do even less surgery, we could help patients maximize their quality of life. Now, the final data for this is expected to be released in 2024. Now, I'd like to say a little bit about lymphedema, that one consequence of axillary node surgery that we can see. This was one of my patients years ago who developed lymphedema, and we found it quite early. It's on her left arm there. But this is not always the case, and many of us have observed or heard of patients with such severe lymphedema that their mobility, their clothing choice, and their daily activities are hindered. The risk of lymphedema with a full axillary lymph node dissection is about 13 to 14%. That risk drops to about 3 to 4% for a sentinel lymph node dissection. So even with de-escalated axillary surgery, there's still a risk of lymphedema. Now, are there any other risks for lymphedema? Can we as providers do anything to minimize lymphedema risk? Well, remember B04, which was looking at radical mastectomy versus total mastectomy and radiation, or total mastectomy alone. This was a follow-up in 2007 on the participating patients' experiences with lymphedema. And this table looks at lymphedema rates. Now, first off, note that the values are quite high. They're much higher than what we see nowadays. But as expected, the rate of lymphedema was highest with radical mastectomy. Lymphedema was also more common in overweight and obese patients. Interestingly, there was a trend toward higher rates in Black women. These other factors, number of lymph nodes removed, age at time of surgery, clinical nodal status, and tumor size had no impact on lymphedema development. It appears that the greatest risk factors are doing surgery at all and extent of surgery. Perhaps the more fat there is in the axilla, the more dissection that is necessary, the greater the risk of lymphatic disruption and lymphedema. Many of us have been taught that things like ipsilateral blood draws, injections, blood pressure measurements, and air travel actually promote lymphedema when women have had any type of axillary surgery. But no studies have supported these assumptions, and they've already been shown to have no bearing on the development of lymphedema. I invite you all to visit breast360.org to read this review of recent literature that refutes those general assumptions that many of us have held for years. On the same website, you can review a statement by the American Society of Breast Surgeons about lymphedema, where they advocate for establishing a surveillance plan, considering getting some baseline measurements of arm girth at different points along the extremity for comparison in the future, minimizing axillary surgery, when possible, constantly educating and reminding patients about the early signs and symptoms of lymphedema, and also encouraging exercise for all of our patients who've had axillary surgery, including weightlifting and resistance exercises. So in summary, regarding de-escalation of axillary surgery with breast cancer, the initial breast cancer surgery did include excision of axillary nodes for staging and for an attempt at disease control. But elucidation of disease biology has facilitated less surgery. Advances in melanoma therapy led to changes in axillary surgery for breast cancer, and further understanding of disease biology and more effective therapies have more bearing on a patient's outcome than clinically negative nodes do. So excising clinically negative nodes does more harm than good. Thank you very much for your time.